So how do you interpret your Stiles screen after you found what we call the speed bumps, the tissue texture changes, areas where the tissues aren't moving as well as we've screened down the articular column, all the way down the spine, starting from the base of the skull, all the way down to the lumbosacral junction? So the first question you have to ask yourself, well, did it feel like that things, T12's kind of your cutoff point for upper half of the body or lower half of the body? So did those restrictions feel worse when you were palpating in the upper half of the body or the lower half of the body? So what we have to remember is we want the most localized, hardest infill restriction, not the diffuse tissue texture changes. We want specifics. So if we're thinking that things were more restricted, T12 or above, we got a lot of different things, structures that we have to process. So the first thing is, was it cranial? So if it's cranial that you need to start as your area of greatest restriction, when you are palpating in the upper cervical area and you did a little bit of flexion, again, relative neutral, but just the least bit of opening to open up that space and adding a little side bending and rotation just into that segment. If you did not feel any muscle grabbing, but you felt a tight leathery band of tissue, you're blending in over that nuchal ligament. And if that is tight, but the muscles or in the tissues all around all the other areas were not catching, that's a sign that it's a dural pull, and that's telling you that the cranium could be the area of greatest restriction if that's the most specific and restricted of all the areas you were feeling. If it's upper cervical, then you're going to have a spring. You're not going to have like kind of a tight leathery band feel. You're going to feel more of the muscles grabbing at the OA and AA in that area. And if you are, then that tells you that either OA or AA is the most restricted area. Then you would need to motion test them and see which one of them is the most restricted, and that would be your starting point. If that had movement in it and you come down and you're palpating over C2 through C7, if you can find a specific hard infield speed bump that you can localize in at one particular segment in that cervical area, that is telling you that segment is the restricted. Now, if it feels tight and it feels diffuse, that is the body telling you that there's a lot of compensation going on in there. The cervical area is the number one place that is going to hold a lot of compensation to all the other dysfunctions in the body, because we can't move, talk, do anything without our neck and head adapting and moving in some shape to keep our eyes level and keep us focused. So if you can't localize in on one particular segment, then that's information that you've gathered, but you're going to just hold on to it because that is not where we're going to start. Then once we get into the thoracic area, we've got different structures there. And again, we're thinking of this in the Stiles screen, we're coming at it from a physiologic model is what he likes to call it. In our current 5 models of treatment we have, we're coming at more of a biomechanical. So our focus with this screen is looking on what is going on from the framework. So if our framework isn't solid, doesn't matter how much work we do in the rest of our tissues, the frame isn't solid. If the walls of this room are not solid, doesn't matter how much expensive, fancy things we put in the room, if the wall collapses, then everything is a loss. So that's where this model is coming from. So once you get to the thoracics, it could be the thoracic segment that could be the restriction. It could be rib cage, or it could be an upper extremity problem. So how we're going to determine that is if when you hit the speed bump, so right here was a little bit of a speed bump here. So when you hit this area, if you can blend in over this thoracic segment, and no matter what vector and blend it in, and you want to blend to the bony segment because we are checking facet motion. So if you blend in to at the bony segment at that facet and you give it a little swing, if there is a vector that you've got give and spring, then it's probably not the thoracic that is the most restricted, because if it's that thoracic segment, then no matter how you spring, it's going to feel kind of like a bony lock. You're not, and the tissues just are not going to have any give motion. And even if you spring really hard, like the body's not going to move. There's adaptability in the spring, especially in this vector. So then that would say, okay, well, maybe it's not thoracic. The other two things we have to consider in this area would be, is it coming from the upper extremity or is it coming from the rib cage? Because the ribs attach onto the thoracic spine. So if we're going to check for a rib dysfunction at that area, if we palpate out laterally, blending into the layer of the bone of the rib, and as we go out, if it gets harder and harder, and again, we're not in soft tissue, we're not in fascia, we are blending to the layer of the bone, and then we're not talking massive force. If you blend in, it does not take a lot of force because your intention is you're going to the level of the bone. So as you spring, if that has a harder infield, and look, I get there, now see, I could really put force in and there's no adaptability to the body. And if it gets harder going out laterally, that tells us that the rib cage is a potential for the area of greatest restriction. It's localized. Now that could be just the rib that has that hard infield. Sometimes in significant rib dysfunctions, there could even be a horizontal band that's coming out. So if we have some vector spring in the thoracic segment where we had our major speed bump, and then we check going out laterally and we get a much harder infield going out laterally and lack of spring, and a lot of times it's going to be very tender to the patients, they'll even give you that feedback, then you're going to say, okay, well, it's not the thoracic segment that I need to start at, that would be the rib cage is where I need to go. Now, if we were right in here, so this is still, 2 through 8 is your sympathetic innervation going to your upper extremities. So if we find a segment within the area of the scapula here, then we want to check to see, is there a band? So in the upper extremity, there can be a band of tension. Now that band can expand the whole entire length of the scapula, but the band is not going to be at the border of the scapula, and it's not going to be in the paraspinals. It's going to be, you start in your articular column. So with our spring, it wouldn't be an individual segment that you would feel, but you would feel like there's a whole band area underneath your thenar eminence that you're feeling as you're springing. So if you're feeling that band, and we've got mobility at the thoracic segment, then you've got to start thinking upper extremity. So in the articular column here, you're going to feel a tightness, but you actually want to come just the least bit lateral to the articular column before you hit the paraspinal muscles and the medial, but you're kind of right at the medial border of the scapula, and that's where you're really going to feel that band's going to stand out, that is going to feel like just a diffuse band of tightness that no localization can occur. So if I show you on the skeleton here, articular column is here. So this is where our motion, this is where we're feeling here. But if it's a band and we say along the medial border of the scapula, we're going to come out just a little bit lateral here to where we're going to feel a band is going to come through here. So that's where you're going to feel, and it's going to be a tight band that you can't get any spring. If you can get individual spring, then it's telling you that it's probably not coming from the upper extremity unless there's a band. Now this band could be all the way the length of the scapula. You could feel it more here in the upper third, in the middle, or the lower third. And all of that's going to come into play. And you think about how the homunculus of the body, there's a huge component with the homunculus for upper extremity. So when we break this down, and I'm going to come back to my patient, if the tightest thing in our screen is going to be this band along the medial border of the scapula, and again, we're not right up against the scapula, we're not in the articular, we're just a little bit lateral to it, and there's a tight band when we give our spring. And if we have a tight band in here, and we don't really have that here, so it's hard to see in visual, but if there's a tight band, If the band is tighter up here in this upper third, you're also probably going to have a lot of tissue texture changes in your hand placement here together, because you're feeling with your fingers, you're feeling what's going on at the SC joint with the clavicle, you're feeling what's going on at the whole clavicle, and you're also feeling kind of what's the tissues feeling like on the upper ribs. And if you're all across through here, you're feeling what's going on at the AC glenohumeral joint. So you're probably, if you've got that diffuse band, also feeling some residual tension in the tissue textures here. So if the upper third is where that band is, you can't localize in on a thoracic segment that individually, you have spring coming out laterally, then that's going to tell you there's something going on in the upper extremity. And in the upper third, you're going to be thinking it's coming from up in here, whether that's the AC, the SC, glenohumeral, subscapularis, something going on in this region would be where you would need to go and screen. If you feel the bands in the middle of the scapular region, then you're going to think probably coming from elbow, ulnar area in there. If you feel the bands coming in this distal third and it's tight, but there's some give and spring in the upper part, then your processing is, then that is coming from the wrist or hands. So, and Dr. Stiles always says a little bit of carpal dysfunction can completely change the whole entire body, because the amount of homunculus used in the brain for our hand function, because our dexterity and everything we have to do and the nerve endings that we have is so important. So band along the medial border of the scapula is going to tell you there's something going on in the upper extremity. Again, we can break that down into thirds as to help us guide us. Almost always the side of the band, of the unilateral band, is going to be the ipsilateral extremity that the dysfunction is in. Occasionally, if trauma has been induced, then fascial wires get crossed and it could be coming from the other side. Now, Dr. Stiles always maintains, you feel a band, go screen the upper extremities, screen both of them. Always treat the most individual restricted segment that you find. But for breaking things down and in your processing of speeding your process up, this can really help lead and guide you where you need to be. Okay, so we've determined cranial, upper cervical, whether it's thoracic, again, thoracic. If you can localize in on one particular segment, and there's one right here. So here, when I blend in and I try to spring, there is no vector that gets me any spring. As I come out laterally, I start to get spring, and you can even see the whole body can adapt and spring because there is movement going on in there. So that would tell me that segment is restricted. And the whole point of this is we're finding the most localized, most restricted individual restriction, and that's where we're going to start. Okay, so now that we've processed the upper half of the body, we have to process what's going on the lower half of the body, which is below T12. So first thing, same as with thoracic, if in your screen you can then you feel a speed bump and you can localize into one particular lumbar segment, and when you spring you can't find a vector of movement, that tells you it's that lumbar segment. You're going to examine that segment, flexion, extension, find what the diagnosis is, whether it's a flexed or extended, side bend or rotated, what that dysfunction's doing. If in your spring you have a band, and again, that band, the same as in the upper extremity, is going to be just lateral to the articular column, but not out into those paraspinal muscles. And if you can't blend in on that band to find an individual segment and it's unilateral, you're going to think lower extremity. So if I come back to the skeleton here, if we're in our lumbar, and again, we're feeling over the articular, there's a band, so I can't localize into one particular segment because if it's a hard infill and very specific, that tells us it's this vertebral segment that there's a restriction that we would need to motion test to get our diagnosis. The band is there, then you're going to feel the lack of spring and it's just going to feel like a tight band. If you just come out a little bit lateral, then the band will really stand out, and it's not in the paraspinals, it's just lateral to the articular, and it's almost right before you hit the edge of where the transverse processes are. And this is where that band's really going to stand out. The same as along the medial border of the scapula. So if you have a unilateral band, the other side is springing, and you can't localize in on a vertebral segment, that's a key that it's in the lower extremity. Now, in the standing position, if the back felt worse in our initial screen and heart and felt just kind of diffusely worse compared to when you sat down, that's another indicator that the lower extremity is involved, because our legs allow for adaptation. But if the key problem is in the legs, it can't do the adaptation that it needs. So when the patient sits down, typically their backs lock up and you'll feel a lot more restriction. But if they sit down and their back feels much better, much more mobility, then that's already our brain processing, thinking there's definitely probably something going on in the lower extremity that may be the key area. And then you would confirm it with your unilateral band. Okay, so that's lumbar. Then if you come over that, and the importance of springing over the lumbosacral segment here is if you spring and you have given spring, but there's a restriction right in there, that's probably the L5 segment. If you come over this lumbosacral and you're always feeling the tissue textures from anything that's touching your patient's body, if there's a band that's going across the lumbosacral junction, a horizontal band, it can either be unilateral or it can be diffuse from both sides as you're springing, and you can't localize in on one particular vertebral segment, that is telling you that the area grace restriction is coming from the sacrum or pelvis. So then you would need to screen out the sacrum and pelvis to then determine where the key is within the sacrum and pelvis. So that is how we determine. But just like with the upper extremity, lower extremity, same thing with the homunculus of the body. There's lots of proprioception, lots of movement. It takes up a big part of that. So understanding this band is similar as the upper extremity. The upper third, you're going to think probably coming for something from the hips and thigh area. If it's in the middle, it's going to be fibula or proximal tibial restrictions. If it's in the distal third of the band, you're thinking ankle and foot is where the problem is. So you can quickly problem solve to know where to go. Dr. Stiles always maintains you have a unilateral band of tension, screen the lower extremities, check them bilaterally, always treat the most restricted individual segment. If something feels tight and diffuse, then that is telling you there's compensation going on and you can't localize in on something in particular, then that's the body saying, time out, I can't completely let go because I'm helping someone else go look elsewhere. So I will maintain that if you follow the Stiles model and screen and finding the key area, that you will only treat type 2 dysfunctions, because our type 1 dysfunctions are compensatory. So they follow compensatory patterns. So if you treat the key, which is always going to be an individual localized segment, whether it be through a band or vertebral segment, going into the extremities or the ribs, cranial, go back and you're going to go back and re-screen after you treat the key area, what you think is the key area. Go back and you re-screen, and it seems monotonous and it seems like it would be very time consuming. But once you get in the hang of your screen, it's very quick, because you'll treat the key and you'll go reassess the body and you'll see that all the tissues have changed, all your speed bumps are different, and you've peeled another layer of finding the next key area. And you'll feel a lot of diffuse tension in the areas that you felt diffuseness have melted away. So usually where you find type 1 mechanic dysfunctions, there's compensation, there's a key elsewhere, you treat the key. When you go back and rescreen, either all the tension has melted or there'll be an individual restriction within that area, whether it be rib or a thoracic segment or a lumbar segment, or there'll be something that will then be localized in that you'll be able to treat without having to work hard, because the body is just leading you to the next layer of help that it needs.